Once again, my gratitude to Dr. Gaurav Luthra, Saurabh Luthra, Dr. Amardeep and Shivam for having me here and the warm hospitality. Really appreciate that. As any other surgery, GDD also is full of complications and we need to understand how to handle them. With the advent of newer GDDs like ECP, where you have a ripcord and Paul implant, we do expect lesser of them, but then nonetheless we should be sure of what can happen and what to expect. This is generally a summary of the previous two speakers that we have already seen the nice videos how to handle the complications. Well, this is how we can list the complications. They can be hypotony related, implant related and others. Hypotony related can be flat anterior chamber, overfiltration and corneal decompensation. So how do we deal with them is we have seen that how it's more implants which are non-valved, and how do you manage them. You put a tight suture to close the channel and follow to close the tube, and then see follow up the patient properly when the ripcord or the suture is opening, and how to manage the hypotony. If there is a corneal lenticular touch, there is an immediate intervention that is required. You need to form the AC with viscoelastic, and cause has to be treated if it is a leak, or if it is opening of the suture or premature opening of the ligature is something that you need to religate. If there is choroidal effusion, you do plan medical treatment with corticosteroids and cycloplegics. However, if there are kissing choroidals or flat AC not responding to the medical treatment, you do need to undergo, take up the patient for choroidal drainage. This is one of the examples. If you look at this, one eye is PL negative and the other eye, the only eye of the patient was already aphakic. Some iridonclesis old procedure was done. The pressures of 42, advanced cupping and just a very poor vision. But that was the only seeing eye. So this is the patient which I have operated long back, where we had done the boweled implant in the left eye. So the first post-op day, the pressures were high because we had put the ligature as expected in a non-valved implant, and tube was well in position. But on post-operative day 8, this patient comes to me with the shallow or flat anterior chamber with IOP being low and choroidals. So it looks like there was a premature opening of the ligature. And as you could see, the choroidals were significant and it was a flat chamber, so we could not wait, and we had to do AC reformation with choroidal drainage, and I religated the tube again. So subsequently the patient did well, and it has been following up with me for many years and has been managing well. The second one can be implant related, which can be tube or plate exposure, tube migration, block or retraction or malfunction. Some of the examples, sometimes there can be malposition. This was a patient referred to me. There was tube malposition inside the lens, so you definitely have to either redirect the tube or shorten the tube. There can be tube block like this with iris, where you can see the tip is obliterated. So you either need to resort to laser if it is amenable and you can open up, make up that opening, or you have to redirect the tube again. Another case, this is operated by me only, a 63-year-old, had undergone a complex cataract surgery elsewhere, and the lens was in the sulcus. The visual acuity was 612 and the fields were like this. Had undergone trab somewhere and was failed trab. So the only option left to me was to do a shunt, and I do prefer non-valve shunt. So I did an AGV for him, and the patient did pretty well as expected. The pressures were okay. However, 10 months post AGV, he comes to me with pain and hazy vision immediately after he landed from a flight. So he calls me from the airport itself that suddenly after landing, I'm not able to see. So I told him to come directly to the hospital, and when I saw him, the pressures were 46, and there was a vitreous strand coming somewhere from behind and blocking the tube. As you can see there in the picture, there's a vitreous coming from behind, as the IOL was in the sulcus, as I told you. And if you magnify, you can see the whole vitreous strand was fed into the tube. So here again, I took him immediately under topical anesthesia. So here the YAG would not work. If you YAG it, this vitreous will permanently block the tube. So you have to remove the tube. So I took up under topical anesthesia and just removed that strand with the forceps, and then did the vitrectomy to push the rest of the vitreous back. And after that, he's been fine, and now I have almost 12 years follow-up. He's been doing fine. So these things can happen. Migration, extrusion and erosions can happen. Dr. Sunita has wonderfully shown those videos how to take care of them. You can use a scleral patch or pericardium or even the tenons which can cover it, and if there is a tube exposure, it is best to redirect the tube rather than keep in the same position, and then repair it, use the amniotic membrane, which can help. If it is large, you might have to remove. So if there is an endothelial touch or iris or lens touch, you need to reposition. If it is a tube block, if it is an iris or a clot, you can use a laser. If it is vitreous, preferably do surgical, because if you cut the vitreous, as I showed you, it can stay. If there is a retraction, then you can use a tube extender. That can happen typically in children. If there is a tube migration, again redirecting the tube may help, or shortening the tube may help. If there is an erosion, you need to definitely repair. You cannot leave it as such. Another patient who was post-K-Pro, I had done an AGB with the pars plana, that was PC7. So patient came to me after 1 year of pars plana clip exposure. So if you look at it, this is how the clip was peeping through. So here what we did was just covered it with a scleral patch graft and amniotic membrane graft, and also because the cause in this patient was a severe dry eye because it was an alkali injury and he was post K-Pro. So we did a tarsorrhaphy in that area so that the exposure is less because the surface was poor. So that is what helped, and then the patient did well. So plate exposure is another dreadful complication which can happen. Smaller plate exposure like this can still be managed by covering, but if it is a larger plate exposure, like in this patient, I advised a coverage, but the patient came after 6 months. By the time the tube plate had exposed this much. If it is this much plate exposure, most of the time you have to remove the implant or explant the implant. That is what we did in this patient. The other complications can be motility disturbances, overhanging bleb, endophthalmitis, or epithelial downgrowth or suprachoroidal hemorrhage. One more case is a child with PCG. He had failed trab and trab in the left eye and underwent AGV. So pressures were quite okay with single medication, but after 5 years, the IOP started rising. And if you can see this tube, it's touching the endothelium and the area of cornea which is getting decompensated. There's a fibrous membrane there, and you can see the touch here. And this bleb around the plate was quite tense and fibrotic. So when I did a UBM over this, you can see there was a thick fibrous membrane. It was as thick, much thicker than the sclera, and this is the body of the valve that you can see. So in this patient, what I decided to do is a tube excision and tube redirection, excision of this fibrous plate around, and patient had also developed cataract, so lens aspiration and PCIOL implantation all was done in the same sitting. So after the lens aspiration and PCIOL implantation in this patient, what I did was just expose this tube and removed it because it was touching the endothelium and was causing the decompensation. So it was quite fibrotic. As I told you, it was 5 years post AGV that surgery was done. So just remove the tube and change the path. Make sure that you are putting it in parallel to the iris plane so that you don't have the tube touch or iris and corneal endothelial touch again. And then close the previous opening. Then I close this incision and then open up another incision there close to the valve body, and you can see this is a thick coconut shell almost developing over the body of the valve. So before you close, just check the tube is patent. So I used a cannula to see that there is a flow through this AGV so that it would be working, and then close the conjunctiva. So this was the post-operative outcome. The tube was well away from the cornea and the bleb had softened down a little. Subsequently, I had a 3 years follow-up for this child and he did well. The other complications can be motility disturbances. If it is not too much, the prisms can help if there is minimal diplopia. If there are significant motility disturbances, then you may take help of squint surgeon to take care of the surgical intervention, to take care of the squint by surgical intervention. If there are overhanging blebs, then you need to strengthen the bleb. If it is raised IOP, like you saw in the previous case, you need to do the capsule excision and repair. Sometimes there can be epithelial downgrowth, and so if that has to be managed only if it is affecting the aqueous drainage. Suprachoroidal hemorrhage should be drained after 7 to 10 days once the blood is liquefied, otherwise you would not be able to remove the clot, and image it if the anterior chamber flattening is there. Endophthalmitis and malignant glaucoma need to be managed as any other endophthalmitis or malignant glaucoma. Thank you for your kind attention.